Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City. And I'm joined by my co-host, Brian Waterman, who's at Wake Forest in North Carolina, who's going to join us later for the interviews. Before we get started, I should mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, Wake Forest, and the institutions of many of our guests. So today, we are in Munich, Germany, at the 2024 annual meeting of SECEC, and we have a stellar episode. We've handpicked some of the best talks from the meeting and invited their authors to discuss their work. I know it can be very hard for American authors to make it to European meetings, but I'm hopeful this will offer you a brief taste of all the interesting work being done internationally and maybe inspire you to attend this meeting or others like it in the future. So to start us off, Dr. Patrick Race and Killian Wegman are joining us. Both are located here in Munich, and they are the co-chairs of the meeting. Patrick and Killian, welcome to the podcast.
Thank you, Peter.
Thank you, Peter, for inviting us.
So I'm sure this meeting has been a huge endeavor, putting together your agenda, preparing to welcome everyone to Munich. Patrick, tell me, what aspects of the shoulder program were you most excited about as you looked at the agenda that you'd put together?
Well, I must say that this year we have really a very outstanding program with an outstanding faculty. As we changed the program completely compared to the other years. Maybe we speak about this later on. I would not like to highlight one speaker or one session. I would just say that based on what we did, we had an acceptance rate for papers around 5%, which is really low. We had 900 abstract submissions. And what I like in this new concept that we developed is that we really bring different aspects into this Congress. So we are completely open. It's the first time that we have an ASES session. It's the first time that we invited ACS to give an own session. It's the first time that we invited the ASES president to give a lecture. And also other stuffs like video sessions, case-based discussion. This is new, and I think the participants like it.
So tell us maybe we could go to you, Killian. Tell us what was new. What were some of the things this year that were kind of innovations on your guys' side?
Well, as Patrick just said, we had a high number of submissions. Therefore, we had to put a lot of them, or had to try not to reject too many. Therefore, we had to compress them, if I can say so, into sessions. That's why we introduced rapid fire sessions. And those were built up in the way that each paper only had 3 minutes for presentation and 1 minute for discussion. That had a bit of a drawback because the presenters felt a bit rushed to transport or transduce their message. However, it was a very, let's say, a quick change between the topics. And in the end, the biggest advantage was that we were able to keep a lot of papers in the meeting and not to have to reject too many. I think that was an innovation that changed the format a bit.
I love the 3 minutes. Tell me, has that been difficult for moderators? Has it been difficult to keep people to 3 minutes? So often people like to hear the sounds of their own voices, you know?
That's completely true. Actually, the chairs were quite nervous before entering into the session because it's the first time that we are doing it. But afterwards, everybody was saying it's quite interesting, these kind of concepts, because the message that you cannot deliver in 3 minutes, you can also not deliver in 7 minutes. So you cut down your slides and you really just focus. And it's like an extended abstract where the main information is inside. And I think it's a good year. We had 900 abstract submissions, and each abstract was reviewed by 3 independent reviewers. And to make a clear cutoff to say, okay, this paper will not make it and the other one will make it, it is just based on 0.0 something points. And there were so many good abstracts submitted, and it would really be a pity to kick them out because we stay to the old format. And I think it's a good idea to keep more people attracted to come to this meeting and also to deliver more information to the participants.
But as you said, Peter, it was difficult to stay in time because the sessions that went over time the most were the rapid fire sessions. So it really was a challenge. because it was also new for many people. However, I liked the sessions because they were really dynamic due to the changes of the speakers and the quick and down to the point discussions. So it felt a bit like watching a sport event because of the dynamics there.
I know, Killian, you're a real expert in the elbow. The elbow is so often kind of ignored, or it's the side room in our meetings. Tell us what you've done in this meeting. I love that you two as co-chairs have really covered both shoulder and elbow. What have you done in this meeting to try and bring the elbow to the forefront, or what have you done differently when it regards to the elbow program?
Well, surely on all the meetings, elbow is dominated by shoulder. On the one hand, by the clinical case numbers, but also by the number of available studies, and the 2 points affect each other, I think, or the dominant point is the number of clinical cases that are available, which also dictates the availability of high-level studies. So, as you say, it's correct. It sometimes is hard for the elbow to shine. In this meeting, I think we had a very fair share of sessions. I think we had, I think it was 60% shoulder overall of the sessions, and even 40% elbow. So I think we reached a fairly high representation for elbow. We were also able to highlight the elbow in some talks, like today, the Birgit Werner lecture was also on elbow. I think that was a nice thing. And tomorrow, on the last day, we have a highlight session for elbow, where some elbow, if I may say so, legends are giving a talk. So we have set some elbow highlights. I think we found a good mix.
Yeah, I just wanted to congratulate you both, because the Bridget Warner lecture day was so well delivered. It was so wonderful to have someone from the foundation speak, and then Dominic Grillo's talk was amazing. Yeah. I want to ask both of you. You saw the agenda ahead of time. You saw the abstracts. Now you're seeing the meeting in person, and obviously you've seen more details. Maybe from each of you, have there been things already where you're going to say, "I'm going to change my practice when I go home. I've seen something that's changed my mind"?
Well, actually, it's you get a lot of information, and it takes time to think about it and to implement it in your clinical practice. And there are so many different messages and outcomes depending on what you read or what you're listening to. So I'm always completely open for whatever the technique, surgical technique, or other things to implement this in my daily practice. But first of all, I would like to think about it, take my time, and then use it or not.
Yeah, for sure. Changing your practice significantly, I think it's not the task of a meeting. It's just to give you small stones to add to your to build your house of medicine that you do. If it would change it completely, it would show that you did something really wrong. But I know the point you're making, and I think what I saw were nice new innovative implants. Think some knotless anchors or whatever you could see in the workshops, for example. I think that sometimes gives you an information that you say, okay, I should try this implant because it adds a little bit of an advantage. And I think that the meeting really showed that there are in elbow, in shoulder, in replacement, in trauma, there are aspects that we find or that crystallize as one of the key problems. And you can see, it's interesting to see that the research community together moves toward them to solve them. So that it was again shown in this meeting.
If I may add something, there was some presentations today in the arthroplasty session which were quite interesting for me because I never heard about this. For example, there was one session for eroded glenoids, or one talk for eroded glenoids, where we in Europe would usually do a bio-RSA, for example. And in this paper, the technique was presented where you do exactly the same but without bone. Meaning you have a gap behind your base plate, and you just put no bone, no bio behind your RSA, if I can say so. And you just fix the base plate with screws in a stilting technique. And this was something I never thought about, and this is it's well functioning, and the results were quite nice. So this is something completely new for me. Also, we got some information about how the caseload of a surgeon may influence the outcome as well as the complications. So there's information that may help us in the future.
Yeah, that latter talk is one that Grant Gergu's talk that I really commend him on. I think it's great work. Maybe I could go out on a limb and say one thing that will change my practice is I watched your technique for removing a well-fixed implant using a saw, which I loved, and then to impact it down. I thought that was a phenomenal, that's at least for me one tidbit that was really helpful. Now, I know from my last visit that the people here are very proud of their Bavarian culture. And I mean, I will say I feel like I barely survived my last encounter with Oktoberfest. So I want to ask both of you, I mean, you're also hosting people in your city. So what aspects of Bavarian culture were you thinking about? How do I introduce these to the people that are coming from all over the world and show them a little bit, not just of shoulder and elbow, but also of, the place that I'm from?
I think the best person to answer this question is actually you, Peter, or John Barlow. Yeah, I mean, it's always nice to have and host fellows. Actually, Kilian is a true Bavarian. He's born here in the state of Germany. I'm not, so I'm more from the middle part of Germany. But it's a very nice and warm culture, I would say. A lot of traditions and maybe a little bit different way of life and thinking. And I think it's part of the game then if you host a guest or a fellow or friends or whatever, that you just share this culture and friendship. Introduce all these kinds of tradition. It's the beer garden, the English garden here in Munich, for example, and other places. Kilian, what do you think?
Well, I think we want to be a friendly and, if I may say, not being political but liberal country. Want to welcome everybody, be inclusive, be open-minded, and that's something we want to transform or give on as a message, and I think that's something we try with this Congress, and we'll try our best to do it tonight at the Bavarian evening. And for sure the beer is going to help to loosen the moods and to elevate everybody's fun on this evening.
Well, thank you both for coming on to speak with us for just a few minutes. Congratulations again on the Stellar Congress. It's truly a huge accomplishment, and I'm sure the culmination of a great deal of work, and I think all the attendees really appreciate all the work you guys have put into it. So thank you both, and we'll look forward to the rest of the meeting. So next up we have Professor Pascal Boileau of Nice, France, who's here to discuss his lecture on the arthroscopic trillat procedure. Professor Boileau, welcome to the podcast.
Thank you very much. It's my pleasure.
Now, you have been a real arthroscopic pioneer when it comes to instability, and you've taught us a lot about the arthroscopic Latarjet, and now the arthroscopic trillat procedure, which is in some ways a variation, but in other ways a different procedure. So tell us very briefly, how does this procedure differ from the Latarjet?
So the trillat procedure has been initially described by Albert Trillat, who was a professor of orthopedic surgery in Lyon, France, in the 50s. And it was a modification of the Noske procedure. So initially it was called the Noske trillat procedure. And this procedure is really based on the sling effect of the conjoint tendon. So the goal of this procedure is to make a partial osteotomy or osteoclasy of the coracoid process at the base of the coracoid in order to tilt down and to medullarize the coracoid process together with the conjoint tendon, which makes the sling effect very efficient because the conjoint tendon is closer to the subscap and it's more medial. It's reinforced what has been called the antero-inferior weak point of the shoulder. As you know, when you put the arm in the throwing position, which is the at-risk position for anterior instability, the subscap is going up and only the labrum, the antero-inferior labrum and the small capsule is stabilizing the shoulder. So when you do the trillat procedure, in fact, what you are doing, you are lowering the subscapularis tendon and muscle, and by this you reinforce the weak anterior-inferior capsule and protect the shoulder to dislocate or to sublux. So it's like having a seat belt in the car. You have really this seat belt effect.
So the sling effect is not so much the conjoint as to the secondary effects it has on the subscapularis.
No, it's both the conjoint tendon and the lowering of the subscapularis muscle and tendon.
So thanks for that introduction. What about the primary indications for the trillat procedure?
So, as I said, it has been described by Albert Trillat in Lyon, and Albert Trillat was the boss of the orthopedic surgery in Lyon. And when Gilles Valge started to be interested by shoulder surgery, his mentor, Professor Henri Dejour, told him, okay, you want to do shoulder? First, you're going to review what we have done with the trillat procedure. So Gilles did a tremendous work. He reviewed 250 patients with more than 10 years follow-up, operated by Albert Trillat himself with this procedure. And he found out that the results were pretty good in terms of stability. There was, at that time, if I remember well, about 12% of recurrence of instability with this procedure. And he found out that it was a good procedure for those patients with instability. At least it was the gold standard in the Lyon school at that time for instability procedure. And the story that Latarget was not an orthopedic surgeon, he was an anatomist and a general surgeon, and the little story about that has been said that one day Latarget was trying to do the trillat procedure, and he fractured the coracoid process, and he had to fix it, and that's why he fixed it with a screw, and it was too difficult to fix it above the subscap, so he went through the subscap. And apparently that's the beginning of the story of the Latarget procedure, from a complication intraoperatively that happened at that time.
So what percentage of your instability procedures are trillat procedures as compared to Latarget procedures?
So I have two main indications for this trillat procedure. Number one is when you have a patient with massive irreparable posterior superior cuff tear with recurrent dislocation, anterior dislocations, with good elevation and no pain. You know, these patients that we see sometimes with the upward migration of the humeral head, you ask them to move their shoulder, they have full elevation, full abduction, no pain, but they come to see you because they have recurrent dislocation or subluxation, and they want a solution. So what can you do? You're not going to do a reverse prosthesis, they have normal motion and no pain. You're not going to do a Bankart. Very often there is no Bankart lesion. It has been described by Ed Craig in clinical orthopedics many years ago. Ed Craig from New York made a very nice paper where he showed that this patient with anterior dislocation and posterior cuff tear, there was no or a very rare Bankart lesion. And in fact, the anterior labrum and the capsule was acting as a hinge and allowed the dislocation or the subluxation of the humeral head. And in fact, this instability was more related to the fact that there was no posterior check rein to prevent the translation and the dislocation of the shoulder. So, of course, sometimes you can repair the posterior cuff, but sometimes you cannot because it's retracted, because it's fatty infiltrated, and so there is no way you can bring something posteriorly. You cannot do either a Hill-Sachs remplissage. And very often, in fact, in those patients, there is no Hill-Sachs lesion, because as I said, the head going out of the socket anteriorly, but since there is a hinge of soft tissue with the labrum and the capsule, there is no impaction fracture of the humeral head posteriorly. So what can you do? You cannot do a Bankart repair, you cannot do a Hill-Sachs remplissage, you cannot do cuff repair, you're not going to do reverse prosthesis. You can do a Latarget, that's an option. But these patients have an intact subscap, so it's a risk at least to take to pass through the subscap. And for me, this is a perfect indication of the trillat procedure. So recurrent anterior instability with normal shoulder, normal motion, no pain, and recurrent dislocation, you do the trillat procedure, and they are very happy. We have reported and published in the arthroscopic journal the results of this procedure in this specific population.
So now that's a very specific patient. It's not that common of a patient, but a specific one in which I think that the argument for how this procedure is very elegantly fits that patient's specific biomechanics. Now I understand you've also used it for hyperlaxity.
Yes. So the second category of patients that I like to do the trillat procedure are the young. So the young patients. This the first group was the elderly patients. Yes, they are usually more than 60 years old with posterior superior cuff tear. Now we are dealing with another population, which are really the young patients, especially the females, around 20 or less, who are hyperlax, which means more than 90 degrees of external rotation, sometimes a lot of internal rotation as well. They have 200 degrees of forward elevation passively. So these patients, especially the females, sometimes they are very sportive. They want to do like handball, basketball, this kind of sports. And when you operate on them, there is little Bankart lesion, labrum tear anteriorly, sometimes no tear. There is mainly a stretch of the capsule in addition to their hyperlaxity. So you can do a capsular shift. It's okay. They have a stable shoulder, but in my experience, they go back to sports like handball or basketball or other sports, and they quit after 6 months or 1 year because they feel their shoulder is not strong enough, not stable enough. So that's why in these young patients with hyperlaxity and very few lesions, so they have no bony lesions, no glenoid wear, no heel sacs lesions, just a stretch of the capsule with a small slot in the labrum anterior inferiorly. I do a capsular shift plus the trillat procedure to reinforce again the weak anterior inferior point of the shoulder.
And so those are two very unique populations as well on the hyperlaxity front. What about individuals that have defined hyperlaxity conditions like Ehlers-Danlos? Is there anything you do that's a modification to this?
Yeah, that's in these patients with hyperlaxity, one of those patients, an additional category is the one with what we call the Ehlers-Danlos syndrome, which means generalized hyperlaxity. Again, that's a good option to do a trillat procedure in this patient population, and it's less risky to do this than a Latarjet procedure because, as I said, it's very often female patients, so it means they have small coracoid, and if you do a Latarjet with a small coracoid in a female patient, there is a risk of fracture, especially if you try to put 2 screws. So I would recommend to do instead a trillat procedure.
Maybe I can ask you about this procedure. You know, there's a clear association literature between subcoracoid impingement and subscapularis tears. So subscapularis impingement being the distance between the lesser tuberosity and the coracoid is reduced, and that it's thought that that contributes to subscapularis tears. Now that I know already is controversial, but how does this procedure affect that distance? And do you have concerns about this procedure in the future of the subscapularis?
That's a very good question, and that's a question that I asked myself many years ago, and I was anxious about that, but I didn't observe any tear of the subscapularis, neither any clinical deficiency in internal rotation after this procedure. What this procedure does is that it limits a little external rotation. But patients don't notice it because they are hyperlax. Sometimes they have 100, 120 degrees of external rotation. So if you remove 20 degrees of external rotation or 30 degrees, you are just at 90 degrees. You're still hyperlax, but they even don't notice it. So that's the main thing that I observe. And I was worried about this coracoid impingement. In fact, with the subscap, there is no problem. There is a problem if you don't put the bone block, the coracoid process, at least tension to the glenoid surface. If you stay lateral, as shown by Christian Gerber, because Christian published on the trillat procedure open, he has shown that if you leave the bone block lateral to the glenoid surface, then you have impingement with the humeral head, then you have pain and you create osteoarthritis. But if you go medial to the joint line and down with the coracoid process, there is no problem. So one technical point is that if you do this operation, you should do the osteotomy of the coracoid at its base, really, not at the orthogonal angle, more proximal, really at the base of the coracoid. So you will put it really down, and you can really go medial with the coracoid process, and then fix it here.
So if I can clarify for a minute, your goal for the trillat is direct bony apposition of the coracoid at the equator or just above the subscapularis?
Exactly. And when you do this operation, what you should do, either if you do it open or arthroscopically, you should put the arm in internal rotation to relax the subscap and to be able to place the bone block, the tip of the coracoid at the right spot, which means just tangent or slightly medial to the joint line.
Now, perhaps I could ask you reviewed the history very nicely. It sounds like the Latarjet was initially actually a complication of this procedure. The way you've described this procedure, it sounds safer and easier than a Latarjet. It sounds like you've been pushing into very specific situations where this makes sense. Why don't we do this instead of the Latarjet? So why not replace the Latarjet with this procedure that may have a lower complication rate and may be easier for surgeons to do?
So that's a very good question that I will try to answer. And when I started to do kind of Latarjet trillat procedure under arthroscopy, one operation that I did is that I did an osteotomy of the coracoid process. I exteriorized the coracoid through a small incision anterior-superiorly, and I shape it as a cylinder, and then I drill a socket in the glenoid neck above the subscapularis, and then I was putting the coracoid inside the socket and fix it with an interference screw. I published this in the arthroscopy journal many years ago, so it was a kind of trillat procedure because the goal was the same. It was just to use the sling effect. And I review my patients, I follow my patients with this technique, and they were happy. It was the same results as the trillat procedure, but done under arthroscopy, just with the exteriorization of the bone block. It was a little like the Kennedy Jones in the knee, you know. At that time I was doing knee surgery, so I had the idea to put the bone block, the coracoid in a socket, and to fix it with an interference screw. But when you do this, since you take all the subscap, so you limit some external rotation, because the more subscap you take under the coracoid, the more you limit external rotation. So it's okay to do it in a hyperlax patients, because as I said, when you have more than 90 degrees of external rotation, if you remove 20 degrees, patients don't even notice it. But if you do this in a regular patient, and especially in a thrower, you're going to limit the external rotation, and you're going to limit potentially the possibility to throw. So the number one, that's the reason I don't do it for everybody, because of the possible limitation of external rotation. Number two, as we know, we have really underestimated the glenoid bone loss in the previous years. And since we do CT scan, we see that there are more glenoid bone loss than we were thinking initially. So the beauty of the Latarjet is that you solve the two problems. You solve the glenoid bone loss, number one, and you add the sling effect, number two, and number three, you really don't limit external rotation with the Latarjet procedure. I mean, the cases where I observed initially in my experience limitation of external rotation with the Latarjet was when I was putting the arm in internal rotation in a brace after the surgery. If you put the arm in neutral rotation for 2 weeks after the Latarjet procedure, I can promise you that you don't have any limitation of motion, because then the conjoint tendon is going to heal in the muscular part of the subscap and not in the tendinous part of the subscap, which will be the cause of limitation of motion.
I'm curious about the natural history of that bone block. So with your closing wedge osteotomy, you're bringing it in close apposition, you're probably getting healing at maybe the angle of that diving board. Is that one that is more prone towards resorption, or you think you're preserving vascularity and therefore you don't see as much resorption?
No, it's a very good question. We didn't observe any resorption of the coracoid process, I think for many reasons. Number one, it's a partial osteotomy, which means we try to keep the superior cortex of the coracoid and to act as a hinge when we medialize and lower the coracoid process. Number two, we don't remove the pec minor from the medial side of the coracoid process, so it's very well vascularized. There is a conjoint tendon, of course. The only thing that you cut when you do this operation is the CA ligament on the lateral side of the coracoid. And if you go back, you will see that it's reattached naturally there, and we didn't observe radiologically or even with a CT scan any resorption of the coracoid process. You may have some few non-union of the osteotomy, but again, without any consequence in terms of pain or limitation of motion.
You know, the other thing that you've innovated on is the utilization of suture button constructs. And so I maybe want to have you touch on that, your evolution from a rigid fixation with screw to that of the button. Have you seen any differences in your results?
No difference in terms of results. But yes, initially when I started to do this operation, either open and then under arthroscopy, I was using a cannulated screw under arthroscopy to fix the bone block in the right position. And then I moved from anchors with buttons and then with two buttons, one in the back of the shoulder, one on the coracoid process. And by using the tensioner, in fact, you can gently placate the coracoid process and bring it where you want it to be. And of course the anchor with buttons or the buttons with suture buttons are easier to use under arthroscopy because it's very versatile. You can do maneuver under arthroscopy and it's easy to do. For instance, if you use buttons, you have to come with a guide at the 3 o'clock position, so medial enough, 5 millimeter medial to the joint line. Then you do the drilling from posterior, so it's very safe. Again, with the arm in internal rotation to relax the subscapularis. Then you drill the coracoid process. You put the button on the coracoid process. You do the osteotomy, and then you bring the suture posteriorly. You pull on the suture posteriorly. You add the second button posteriorly, and you have a very good fixation because again, suture buttons are very solid because it's like a bolt. And so there is no pull-out possible, and I didn't observe any pull-out, any breakage, because I think actually people, at least surgeons, do not realize that sutures, textiles, are as strong as metallic wire or cables. So I'm really not worried about any loss of fixation of the suture button.
Well, this is it's fascinating work with great clinical results. It's another innovation you've developed, and so a hearty congratulations to you for all this work. And I really appreciate you coming to take the time to share it with us, and I'm sure our listeners will love it. So thank you again. I hope you have a great remainder of your time here in Munich.
Thanks to you. It's a great pleasure to speak with you.
So I'm sitting here with Dr. Berte Boe, the head of the arthroscopy unit at Oslo University Hospital in Norway, who's here to discuss the instructional course lecture setup. Is dynamic anterior stabilization, the DAS, replacing their traditional instability procedures? Berte, welcome to the podcast.
Thank you so much for having me. It's a pleasure.
And joining us as a guest co-host is Dr. Alex Laderman of Geneva, Switzerland, the inventor of the DAS. Alex, welcome to the podcast.
Thank you so much.
Okay, so Berte, tell us what inspired you to set up this instructional course lecture. What interested you in the DAS, and how do you think you're maybe going to learn from this, or other participants will learn from it?
Yeah, traditionally we have been using the Bankart procedure or the Laterche procedure, many of us, and I do have a lot of instability patients, and some years ago I started to do the arthroscopic Laterche, so that has been my technique if the patient has some kind of bone loss. But then I saw this new technique from Colleen and Laderman, and I also have some good friends in Portugal who has evolved the technique, Angelo and Acevedo. So I've been interested in DAS, and I have been wondering maybe more of us should expand our toolbox and include DAS as a procedure in between Bankart and Laterche. So that's why I set up the ICL, and I'm really looking forward to hear what the faculty will say about it.
So, Alex, maybe you could tell us, how did you think of this idea? What is the DAS? And then when are you using it?
So the story started in 2016. I was seated with Phillipp, my friend, in a hotel during the Paris roller course, I think, something like this. And he said to me, so we drank some whiskey, and he said to me, Alex, I had a bad and crazy idea. And I said, okay, Phillipp, what is it? Because I felt he had, he had something to say, and he said we could do stabilization not using the short head of the biceps, but the long head of the bicep. But it's crazy. We are not going to do it. And I look at him and I said, okay, it's a great idea. Let's do it. And this is how it started. And to answer your question, so we did initially. So we went to the lab, did cadaver labs, evaluate the length of the biceps that we had to introduce in the glenoid if we wanted to do inlay technique. We also reviewed the way we were doing the split of the subscap that is not so easy during arthroscopic Laderman. And progressively we went with the idea that this surgery could be efficient. This is how I started to do it on my patients.
Which patients? So who for you is the DAS patient? What does that patient look like?
So the indication has changed with time. First of all, of course, I was enthusiastic and I proposed this technique to many of my patients, even patients that had consequent bone loss. And I had some failure, so we went back to the lab and did biomechanical study, and we observed that if the bone loss is too important, the effect of the DAS, so the effect of the biceps that is pushing the human head posteriorly is so important that the human head does not even reach the native starting position. And this is at this moment that I realized that probably that a bone defect, so above 20%, like subcortical bone defects or everything that will be above, was not good indication for the DAS. So today, and I also have to mention that I had recurrences, probably due to technical errors, but also to indication of surgery. So I moved back, and today I still doing at least 90% of Laderman, and the DAS is for me a perfect indication for young hyperlax patients that don't have anterior bone loss, and this is for me bad indication for Laderman. Patients that so have slap lesion and so on. So this type of patient, limited bone loss, young hyperlax patient, and slap lesion.
So Alex, how many of these DAS procedures would you say you've done at this juncture? How many patients have you done with the DAS procedure?
I did 60 patients, 56 patients yet. And we published the first series with the technique and then the 2 years result. And I decided now to let the other one publish, because I think that if an inventor, just continue to publish his results, we don't have a realistic answer. And I think that this technique has now to be confirmed by other groups. Otherwise, it has absolutely zero value. So we need prospective comparative study, and we need long-term follow-up and studies coming from other groups now.
I think that's both very humble and important as you consider things like external validity and making sure there's not a performance bias. Berte, you and I have a zero count on the DAS procedures, and so I'm curious, as an early enthusiast of arthroscopic Laderman, where do you see this fitting into your algorithm? We often see issues related to hardware and bony resorption. Is it for that individual with more nominal degrees of bone loss? Where would you see this fitting in?
We have this never-ending discussion on how much bone loss can we accept before we need a bony procedure. And I have to admit that you were mentioning 20%, then you will not do the soft tissue procedure. For me, in many patients, I start to think of the Laderman, even if they have just a little bit, just 5%, just 10%. I start to think of the Laderman. And I'm very happy with the arthroscopic lattaché, but it's time-consuming, it's challenging, and it's proven in the literature that it has higher risk of complications compared to a soft tissue procedure. So, of course, if there would be something in between the Bankart, who is often not sufficient for the young athletes, I would like that. So, and also when it comes to the technique, I know how to do the arthroscopic lattaché. I know it might be a challenge with the split and stuff sometimes, but maybe the most challenging is to get the bone block through the split into the right place. So with soft tissue, with the biceps tendon, I think that might be easier technically, and that's why it's available for more surgeons as well. So I think absolutely there's room for a procedure between Bankart and lattaché, and that might be the DAS.
Always try and think about what are the downsides, and I think one of the downsides here is the potentially damage to the subscapularis. So I wanted to ask both of you, when you do a split of the subscapularis, open, we're traditionally taught that to do it in the muscular portion with the scissors. When you do that arthroscopically, are you doing that with cautery? Are you trying to do that as a traumatic split? And maybe the same for you, Alex. I know you've done both open and arthroscopic latarjet. How are you managing the split between this procedure and the latarjet? Are you doing it the same way? Tell us a little bit about that.
Yeah, so when I do the split in arthroscopic lattaché, I have to go a little bit into the tendon, absolutely, yes. And then when I come into the muscle, I often try to just expand that bluntly, so you have the opening that you need, because if not, you're going to struggle to get the bone piece through the split. So I think you will, I don't know the technical parts of the DAS that well, but I've seen it demonstrated several times, so I think that making the split for the biceps tendon would need to be smaller and maybe then a little bit easier than for the lattaché.
So the first point is, I think, that a split of the subscapularis, as we are doing today, do not damage the muscle part. And we have very nice studies, namely coming from the Balgrist with Carl Wieser, that shows that in the long term, the muscle belly is still nice and you don't have any fatty infiltration after latarjet. So I'm not afraid of the split. Now, when I do an open latarjet, because I stopped to do arthroscopic latarjet, when I do an open latarjet, I only open the muscle belly and I just spread the fibers. I don't burn them. And when I see some arthroscopic latarjet during live surgeries, I have the impression that we burn quite a lot of muscle fiber. So it's not always so nice. And this is why we have been thinking, and we developed a new way to create the split. So the key is to, at the beginning of the surgery, to open the capsule horizontally from the joint, and you just expose the muscle belly. And then you will push your biceps in front of the subscapularis, between the subscap and the conjoint tendon with the suture. And with a clever hook from the posterior portal, you find, so you go through the joint, you find the split, go through the muscle, and you just grab your suture. And as you are in the muscle part, when you pull your biceps into the joint, the biceps should come really easily. And at this point, with the biceps on the tension, I ask my fellows to do some internal and external rotation, and this creates automatically a split, like I will do with CISO during an open latarjet. And we did a cadaveric study and showed that if you do so, the length of the split is usually around 2 centimeters. That is far enough to avoid range of motion limitation.
I'm hoping you both can help me with a conundrum that I think we face right now. So Phillipp Morodor performed this randomized clinical trial that compared iliac crest to the latarjet that shows no differences. And so I think one conclusion you can make is the sling effect doesn't matter for stability. And then we have this procedure and the arthroscopic trillat that are all entirely based upon the sling effect that also shows that you can stabilize the shoulder. So I feel like I'm in a little bit of a conundrum. Like, is the sling effect everything or is it nothing? How do you, with every the evidence we have right now, how do you understand the stabilization importance of the sling effect with regards to these procedures?
Yeah, well, we don't have the exact answer for that. That's why you're asking. So I have stick to the lattaché and not done the bone block. It's partly because of the sling effect, but it's also because it's a local available graft. because if you do the bone block, you either have to use allograft, which might resorb even worse than the autograft, or you have to go to the iliac crest. So that's also a reason for doing the lattaché. I did first the lattaché with screws, never repaired the capsule. The patients are still stable. I was a little bit concerned when I switched to the endobutton technique for the lattaché if I then had to repair the capsule in every patient. I have not done it, and so far they have also been stabilized. So if that's because of the sling effect, or I know that Boileau hardly argues that you have to repair the capsule in every patient, but obviously many of them are stable without capsule repair.
So all that I know about the sling effect is based on cadaveric studies. There was the famous cadaveric studies from 2013, I think, Yamamoto, and they showed that the sling effect was really biomechanically was really important. And several studies now confirm that the isolated Burkhardt is less stable than a Burkhardt plus a DAS, is less stable than an isolated DAS, than an isolated DAS is less stable than a DAS plus Burkhardt, and that both are less stable than a Latarjet. So it's only based on biomechanical studies. I agree with your point. The study of Phillipp Morodor showed that there is no real difference in the outcome between a Latarjet and an iliac crest. However, first of all, they didn't talk a lot about the complication related to the iliac crest harvesting. That is, for me, a main problem, a main concern, because this is really painful, first point. And then I think that they do not answer a crucial question. There is no study that showed that you can revise an adenibinet with a Latarjet. It does not exist. There are a lot of studies that show that you can revise a Latarjet with an adenibinet. So my question is, why don't we start by the beginning? We start with a Latarjet, and if it fails, then we go to the iliac crest.
What do you think the natural history is of the long head of the biceps? Do you think it calcifies? Do you think that's essentially a labral reconstruction? Or do you think that there is a potential role for it in creating more of that suction seal?
So I have some, due to my experience, so first of all, I had some failure and I revised 4 of them with Latarjet. Interestingly, I systematically found the long head of the biceps that was passing through the split. So this structure remained at the same place and incorporate into the graft. So this is the first thing. The second thing, it's so easy to control postoperatively your DAS, because with ultrasound you see perfectly the biceps in front of the subscapularis. So it's really easy to confirm that the biceps is at least still in front of the subcap. Of course, you don't see what's happening behind, but postoperatively, I think it's the ultrasound is a great tool. So yes, the long head of the biceps stay. Yes, it incorporates, and we did MRI that show it. Of course, is it sufficient? Is it enough to provide a stable shoulder in every single condition? Definitely not.
Well, thank you both for this work. It's really, I think it's a great advance forward for us, the DAS, and I think it gives us increased understanding of the importance of the sling effect and its ability to stabilize the shoulder, and when that can work and when it doesn't work. So I congratulate you both on your work here, and it's great for you to come speak with us. We really appreciate your time. I'm sure listeners will find this great.
Thank you so much for having us.
Thank you for the invitation.
So next up, we're joined with Dr. Phillipp Morodor from the Schultes Clinic in Zurich, who's going to discuss his paper, The Critical Role of Posture Adjustment for Range of Motion Simulation in Reverse Torsional Arthroplasty Predictive Planning. Phillipp, welcome to the podcast.
Thank you, Peter, for inviting me. It's a pleasure to be part of this podcast.
And then in addition, we have Dr. Steve Parada from the Medical College of Georgia, who's been kind enough to join us as a guest co-host, in addition to my usual co-host, Brian Waterman, who's also joining us. Steve, welcome to the podcast.
Thank you guys so much. Excited to be here.
Okay, so Philip, you've been going in this direction now for a couple of years and have really already advanced our understanding, but tell us what inspired you to do this specific study.
So I think I can break it down to questions that I was facing that were made by students while I was doing reverse total shoulder arthroplasties, because they constantly asked me, why do you select your humeral component retrotorsion to be 20 degrees, for example? And I was never able to give a good answer. And that's how everything started, because we actually started to investigate the ideal amount of humeral component retrotorsion. And while we were trying to study that, I figured out, well, this discussion is quite difficult to answer if we really do not appreciate the fact that the scapula has a very variable internal rotation.
And then tell us the specific study that you did. What did you do and what did you find?
So what we did is we analyzed the correlation between the scapular internal rotation and the amount of humeral component, as I like to call it, retrotorsion as opposed to retroversion, which would give you an ideal opposition of the components. So in theory, the ideal humeral component retrotorsion equals to the degree of scapular internal rotation. Obviously, you need to deduct a certain degree of resting position internal rotation. So if a human being is standing straight, usually has a slight internal rotation. It's not standing with his arms sticking out straight, right? And so what I did in this study is that I calculated the amount of scapular internal rotation and we deducted the resting position, which would give you the theoretically ideal humeral component retrotorsion, which allows for neutral opposition of both components. And maybe to make an easy example, because this is a quite complex problem, I believe, to just imagine this virtually. If you think about your reverse total shoulder arthroplasties, once you have implanted them and then you try to externally rotate, sometimes you will observe a gapping in the front between the glenosphere and your liner. If you observe that, likely your opposition of the components is a little bit unbalanced and you have not enough humeral component retrotorsion.
Okay, now I want to collect everyone else's thoughts on this, but before we get to that, I just want to address the first thing. So you're saying you look at where the scapula sits in its rotation looking from the top down, and then you match what you're doing on the humerus to match that into rotation. Can I challenge you, why are you fixing the scapular problem on the humeral side? Why not fix that on the scapular side with more retroversion of your glenoid component?
So that's a great point. I just feel like that on the humeral side, right now at least, you have more opportunity for larger change, because obviously on the humeral side you can twist and turn your component quite a lot, while on the glenoid side you're limited by the anatomy of how much you can do in change of retroversion of your component, for example.
Yeah, I think this is a brilliant study, and so I think it goes so well in line with the other two studies that you've done, kind of looking at this, because I think it's something we all look at this planning software. We put in our components. We think the planning software has no doubt it's helped us really get our base plate exactly where we want it, especially if we're making up for bone loss on the glenoid side. But now, as planning software allows us to kind of look and see what the motion is going to be, you bring the arm up into forward elevation and it impinges on the acromion, or you internally rotate and it turns red because it hits the coracoid. And we all know that that's not even how the arm moves. We don't just move our arm in one plane anyway. I think it's interesting though, as we look at this with range of motion, I think we would all disagree on what a patient's range of motion is, because our patients, they compensate through their lumbar spine or their hips even. And so I think as you've looked at this and is there something better that we should be looking at than just these absolute values of like forward elevation or abduction? Should we get rid of range of motion and just look at what they're able to do functionally? Because it seems like understanding it more makes us disagree more about this.
So I mean, this brings us right to the study we are currently discussing. I feel like the preoperative planning is a wonderful tool that helps us in clinical practice, but there's two components to it. One component is that it allows us to place our components so that they are well fixed to the bone. So it allows us to judge, there's a granite bone loss, how do I need to place my central K-wire to get a good fixation of my components so that they won't loosen primarily or secondarily. That's been working wonderfully, and also there is some technology that allows you to bring your planning to the table. So there's nice inventions out there. What they also included in their preoperative planning softwares, and this is true for all companies, is this simulated range of motion that you just mentioned. And as I was processing these thoughts that I just mentioned to Peter previously, I was trying to do some planning on preoperative planning softwares, and what I realized is if I input CT scans from patients with a very protracted scapula, so very kyphotic patients with poor posture, and I input them into these softwares, all of a sudden the scapula was sitting up straight in space, just neutral in space, and moreover, the humerus was just aligned parallel to that scapula. And I was like, hold on, that's not the CT that I uploaded. I uploaded a lady or a gentleman with a very, very horizontally oriented scapula in space, and the humerus almost aligned 90 degrees to that, because obviously the humerus is aligned to the global reference system, so top and bottom in space in the room and front and back, right? And the programs are actually made in a way that they place the scapula and the humerus in a neutral position. And then we further investigated and found out that not only the initial position of the scapula and the humerus is wrong, but that also the kinematic planes are then aligned to this wrong orientation of the scapula, because they take the scapula as a reference system. And this leads to a problematic triad of wrong scapular position, wrong humeral position, and completely distorted kinematic planes. And so when we figured that out, we said, okay, let's do a study and quantify how big would the mistake be in simulated range of motion if you don't adjust for scapulothoracic orientation and posture versus for adjusted scapulothoracic orientation. And yes, we published some in this study some degrees, but honestly, it's not about the degrees in this study, because the degrees are likely wrong as well. They are true for the simulation and for the study purpose, but all these simulations are based on supine CT scans. So the degrees that we mentioned, which are large differences, we see average, I would say, systematic deviations of 30 to 50 degrees on a range on scale from 0 to 90 or 0 to 180. And this is likely even worse if we would take CT scans from standing patients, as usually the posture gets worse once a patient stands up.
Yeah, your study is fantastic in that it really helps to account for a lot of these variables that we really haven't previously considered. In my experience, there's a disconnect between our preoperative planning and reality, and specifically as it relates to internal rotation. You know, that's the holy grail, that's the sweet spot that I feel like tweaking it on the glenoid side, on the humeral side, we've really shown that we really don't have great predictors for it. In your experience, what's the best sweet spot to obtain internal rotation in these patients?
I don't know, to be honest. I really don't know. I think there is some things that you can do that might improve your simulated range of motion, that I truly believe in, but it does not necessarily translate to clinical reality, because even if we adjust for scapulothoracic orientation, and Peter Chalmers and his colleagues have shown this nicely, there's scapular kinematics that come to play and are very important to obtain internal rotation. There's patient-specific factors, general body mass indexes, pre-op internal rotation, and so on. So there's remnant cuff, soft tissues, and so on. So there's so many variables in reverse total shoulder arthroplasty that I cannot give you the recipe. I can just tell you that when we did these simulations, what we realized is that there is definitely a change in internal rotation that we can see, and in extension especially, that we can see if we simulate with posture adjustment versus non-posture adjustment. So the values get much, much lower. So they're more closer to reality, because in clinical reality we are facing poor internal rotation. While in the simulations, the traditional simulation, conventional simulations, we actually get quite nice internal rotation always. And there's a discrepancy there. But with these posture-adjusted simulations, all of a sudden, especially the extension drops quite rapidly, and also internal rotation drops. And so bony impingement might be part of the problem, but might not be the only problem.
So now you just mentioned posture-adjusted simulations. You mentioned earlier adjusting the torsion based upon the patient's scapular interrotation posture. I guess what I want to ask, based on the research you've done, how has it changed your practice in terms of your current application? And then maybe project into the future, if you look 5 years down the road, how do you think it will change our practice as we continue to march forward with our understanding of this problem?
So, since I don't have a clear answer yet, I have made little adjustments to my clinical practice. One would be, for example, if I have a patient with a very upright posture, let's say you, Peter, right? Your posture type A, according to the ABC classification, A plus, right? So I would go for a little bit less retrotorsion. When I was taught reverse total shoulder arthroplasty by Herbert Resch some years ago, we actually aimed for very low humeral component retrotorsion, because what he always said is, Philip, they need to obtain internal rotation. And so if I would operate on you with a very retracted scapula, with good or very low internal rotation of the scapula, I would actually go for less retrotorsion of the humeral component in order to allow you to have a better internal rotation, in theory at least. Now, if I have a patient with a very protracted scapula, very severe internal rotation, you can sometimes see them on the CT scan with these barrel-shaped chests, very internally rotated scapula, then I would actually pick a little bit more humeral component retrotorsion, because by doing so, you will have a nicer position of the components in a resting position of the arm. Because otherwise, you will see what I mentioned previously, some gapping in the front and very early posterior inferior scapular notching during already neutral external rotation.
Sure, by the time I need my reverse, I'll be migrated to the type C.
Might be.
But we'll see. Give me time.
So I have a question for you. So I had a patient, a lot of adult onset scoliosis in her. So on her operative side, looking at her scapula was so protracted it was almost like looking at the en face view of her glenoid, and so. And it was the same thing, of course, I put her into the planning software and I'm like, okay, this does not represent the position. And so I chose to use a posterior augmented base plate from a contralateral shoulder to bring her glenoid back to hopefully help with her external rotation. I was worried otherwise, as soon as she could rotate an arm that hadn't moved in so long, she would dislocate. So are there adjustments like that for posture that we should be making some of these adjustments on the glenoid side, like Peter was talking about? Is there anything like that aside from just adjusting the torsion? Are there any things that you're doing on the base plate in these patients?
Again, great question. And I think Peter actually answered part of this question already with his nice study where he looked at inclination, for example, of the glenoid component and the scapulothoracic orientation. Because in the end, what we are discussing is, can we adjust 5 degrees or 10 degrees on the retroversion? How much inclination do we need? I think the discussion should be, how can we fix our glenoid component well? And then the discussion whether we should be going for 5 or 10 degrees of retroversion and how much inclination. It's really a discussion that is maybe not to the point, because what we are trying to do is adjusting the curtains in the Leaning Tower of Pisa. We are not realizing that the scapula is oriented differently in space. So retroversion of the glenoid component of 10 degrees for you might not be the same as it is for me, because my scapula has a much worse orientation than yours. And so it's different, the orientation in space. So yes, I think what you did in this particular case can be helpful, but you will only be able to adjust maybe for a couple of degrees, because otherwise it gets technically demanding, I guess. Maybe the humeral side is a little bit easier right now to adjust for.
Yeah.
Well, this is fantastic work. I think it's an exciting new frontier for the reverse to understand not just how do we interact with the scapula, but how do we interact with the scapula that's connected to the rest of the body, which is really what the patient cares about. So I congratulate you on it, and I really appreciate you coming to talk with us about the work. And I think that listeners will find this interesting as they approach the patient with reverse, but also specifically that situation, the situation where there's kyphosis or deformity of the chest wall or malpositioning or malposture of the scapula. So thank you so much, and really great work, and enjoy the rest of the time here in Munich.
Thank you very guys. It's been a great pleasure discussing this topic with you, and thanks to the ASES for inviting me to this podcast. Thank you.
So joining us next is Dr. Stefan Moosmayer of Martina Hansens Hospital in Sandvika, Norway, who is here to discuss his lecture, 15-year results from a randomized comparison study between tendon repair and physiotherapy for small and medium-sized rotator cuff repairs. Professor Moosmayer, welcome to the podcast.
Thank you very much for the invitation.
So, Professor Moosmayer, I think most listeners will be familiar with your randomized clinical trial, but perhaps you could very briefly describe the study, which is again now in its kind of 15-year results stage.
Yeah, the idea when we started the study was that in fact, we didn't know whether the surgical treatment or the conservative treatment would be best for small and medium-sized rotator cuff tears. When I looked at the literature, there was no randomized study comparing that, and that is now 15 or 20 years ago. So I am working at a small hospital in Norway, but we have quite a lot of rotator cuff tears, so I thought that would be something we could do at our hospital. So we just started. We found the patients. We made a good protocol. We included, and we randomized to primary tendon repair in the one group and to physiotherapy in the other group, but with the option of a secondary repair if the patient didn't have effect from physiotherapy. And then we started to follow the patients and found the results.
Okay, so we're now 15 years after that process of randomizing the patients. Tell us, what are the results at 15 years in terms of physiotherapy as compared to repair for small to medium rotator cuff tears?
When we have a look at the graphs showing the results, we can see for the first that both physiotherapy and tendon repair give an important improvement from baseline to the early follow-up. At 2 years, the result on our outcome measures are close. They are a little bit better for surgery, but on the constant score, for example, it's a 3-point difference. That is not very much. But then when we follow the patients further, differences are increasing. And after 15 years, we have the largest differences. For example, on the constant score, the difference goes from 3 points after 2 years to nearly 12 points after 15 years. And that is the same, we find the same on all our outcome scales.
Okay, so if I'm understanding you correctly, with this highest quality of evidence, and now with really very long-term follow-up, repair is superior with respect to outcome as compared to physiotherapy. So would you say, based on these results, that operative treatment should be our primary approach, or should be indicated for patients who would fit within the guidelines of this study?
I think there are several things we shouldn't forget. First point, also the physiotherapist patient had a good result, even after 15 years. They are much better than they had been at baseline. So the surgical result is better, but it is not sure that all patients do need this top result. So I think it is still a point of discussion between the patient and the doctor what to do. In my praxis now, if I have a younger patient, let's see a patient around 60 years, with good conditions for the tendon healing, meaning no diabetes, not smoking, no other comorbidities, and maybe a patient who is still working with shoulder demands, I would clearly tell him, I think for you an operation will be the best solution. But if I have a 70-year-old retired man, diabetes, maybe a high BMI, and no big shoulder demands, I would tell him there is a possibility to train you, and it's a much easier way for you to get your final result, which is a little bit inferior maybe to operation, but I think for you it fits better.
Now, Dr. Keener, you provided commentary on the 10-year results of this study when it was published in JBJS and have contributed so much to our understanding of the natural history of rotator cuff tears. Tell us, how do you think this study alters our understanding for the treatment of rotator cuff tears, especially in light of this new longer-term follow-up?
I think this data, first of all, is the best data that we have. And if you look at all, rotator cuff treatment options, you look for level 1 data, which is really hard to execute in the United States. So first of all, congratulations on completing an exceptional study that's very valuable. I think my take-home message from Dr. Moosmayer's work is that as there's an incremental amplification of the benefit of surgery over time, and that relates to most likely healing of the repair. So not all of these repairs are going to heal, but the difference, the nominal difference that you see early on is amplified as time passes. So that makes me believe, at least at some level, that surgery may interrupt the natural history of the disease, and the importance of that is not picked up on early. It seems to be more evident, especially if you use MCID as your definition of success. It's more evident as time passes.
Dr. Moosmayer, first off, congratulations on your recent award for this paper. It certainly is a reflection of your contributions to the literature, and we've often followed your papers, I think, for guidance on this. Many of us look at the study of Jed Kuhn and the Moon Group, and many would see your results as contrasting with this, but maybe it builds upon it, and it shows how the disparity gets larger over time. I'm curious, you mentioned some things about patient selection. What about tear properties or tear patterns? Are there any specifically you would think would be ideally indicated for surgery, such as a cable involvement, delamination? Maybe if you could speak to tear patterns as an indication for surgery.
We haven't thought about that when we started the study, so that was not planned. But I have read the results from the Keener group according the cable disruption, and of course this would be a very interesting thing to look at in a future study. We in retrospect we have had a look on our patients, and are there maybe some subgroups which could be of interest, but all this wasn't planned in the beginning, so it's difficult to do that afterwards. And I also think that our study is not powered for that. It's too small. But I think there are a lot of interesting ideas that should be followed up. Especially the increasing tear sizes. There we have a lot of information from your group about the increase of tear size over time and the association of these increases to decrease in shoulder function. And I also think that this is the key of the condition, that an unrepaired rotator cuff tear is not a stable situation. And this will influence on the long-term results.
Professor Moosmayer, both you and Dr. Keener have really helped to delineate this natural history, which is that if you take a rotator cuff tear and just follow it over time, the tear increases in size and the muscle atrophies, and that has consequences for the patient in terms of their function. I think that we as surgeons really hope that when we repair the tendon, we can interrupt or alter this natural history. And that remains, I think, something of an open question and a subject of some debate, but I think we as surgeons all hope that we achieve that. Do you think that your study, when you see this degradation over time in the physiotherapy group and perhaps not the same degradation in the surgical results, supports that we're interrupting the natural history, or you think that we don't really know that based upon this study?
I think the study indicates that we can do that, yes. In our study now, we had, if you look at the 15-year, the anatomic 15-year result of the repaired tears, we see that there is quite a large number of tears which hasn't healed. I think it was it was 63% which were healed, and the rest were not healed. I think there were 16 tears which were not healed, but of these 16 tears, there were 6 with a partial thickness tear only, and the other 10, there were 2 people who had a new adequate trauma during follow-up. I mean, 15 years are a long time. So, and the tears which are healed have a better result, but the difference is not so large. The healed tears, I think they are a little bit above 80 points on the constant score after 15 years, while the non-healed tears are around 76, which is not bad. And the problem always is a tear which isn't healed, we call this a ray tear without specification, because it is very well possible that a tear which, let us see, was 3 centimeter at the operation and is called a re-tear after 15 years, but then is only 1 centimeter large. Then we have reduced the tear size by 2 centimeter. It's a re-tear, yes, but it's a success, because the tear is not longer as large as it has been. So the definition of a re-tear should be more specific to really understand what we are doing.
Yeah, I think that's a very valuable point, is not all re-tears are the same. We know that if you have the absence of a re-tear at 1 year, you're going to have a fairly durable shoulder. But if you look 10, 15, 20 years later, there's 20 to 40% of these previously healed repairs are starting to re-tear again. But it's a little bit of an injustice, I believe, to label a smaller full thickness defect as a re-tear when it may not be the same size as before, and the implications of having a smaller re-tear may be less likely progression of muscle atrophy over time. Maybe the glenohumeral kinematics on a smaller re-tear are less profound than if you had not originally fixed the tear in the beginning. So if you have a larger tear that goes untreated, you're more likely to have progression of cuff disease and alteration of kinematics. So I think Dr. Moosmayer brings up an excellent point. Not all re-tears are the same.
On the flip side, I also think that not all physiotherapy is the same. Certainly ASES is a little different in Europe, and maybe if I could ask you to dig in a little bit on your recommended physiotherapy protocol as well as the duration, because I think that could be an area for learning on our behalf too.
Yes, I think that is a very important point, because in our study we used shoulder specialized physiotherapists working at our hospital. So these patients got a gold standard of physiotherapy, and I know that in real life this is not possible. When I send out patients to a physiotherapist outside my hospital, they get a totally different approach, which is, in my opinion, not as successful. And so it's a problem to optimize the treatment in a study over the level that you can give in real life. What is the perfect protocol for physiotherapy? I don't know. And I don't think that physiotherapists do know it either. So that is, I think that is a big discussion. I can't really answer that.
Well, congratulations on your work. These studies are incredibly difficult to do, both in getting the patients to randomize and then in following them for 15 years. So this is an unbelievable achievement. And I think that we, as a field, really owe you a big thanks for having dreamed up and then executed this extremely difficult but extremely valuable study. So I'm a big admirer of it, and it's a big honor for us to have you on. So thank you for sharing all of these findings with us and for the work that you have done.
Thank you very much. Thank you.